Welcome to Conversations and Coffee, where we have conversations that are authentic, lighthearted, and purposeful. Our conversations will be engaging. You will hear from industry experts that will have you saying, "Whoa, wow, I didn't know that." Join us, because it's all about you, your loved ones, and anyone who want to stay informed and, of course, living your best life. Hello, everyone. Welcome to Conversations and Coffee. I'm Dr. Joy, the host of this show. I'm glad you are here eavesdropping on today's conversation. Today, we have with us Dr. Michael Samarkos, who is currently the Regional Director of Clinical and Consultant Services with Guardian Pharmacy of Orlando, Florida. He has more than 20 years of experience in pharmacy. He is a current member of the American Society Consultant Pharmacist, where he works daily to expand the role of pharmacists and is especially interested in the pharmacist's role in the transitional care setting. I don't want to say too much about him because I want to give Dr. Michael the opportunity to tell us more as we dive into medication, do's and don'ts from a pharmacist's perspective. So wherever you are tuning in today, get your coffee. I have mine. Michael, do you have yours?
I do.
All
It's
right.
right here.
All right. So let's get started with this conversation. So Michael, I've told our eavesdroppers a little bit about who you are. Why don't you continue your bio and tell us a little bit more about why is your job as a pharmacist important?
Going back a little bit on my bio, since you already let the cat out of the bag, that it's been a super long time since I got out of school. I tell my kids, when I got out of school, there was no white beard. It was still dark, and they don't believe me, but
I can relate.
So I started out coming out of pharmacy school as a retail pharmacist and dabbling in long-term care, but it was never really a focus. It was always how many prescriptions could you fill for however many people, in a given amount of time. And what I discovered really is I continued to dabble in long-term care. I left retail. I went to work for 11 years for one of the hospital systems here in the state. It was a great time, great hospital system, smart bunch of people, great education, totally different than retail, but, another side of pharmacy. And again, all the time, still dabbling in long-term care. But what I realized is the job of a long-term care pharmacist or a consultant pharmacist, which in the state of Florida, you have to have a separate license to be a consultant pharmacist and work in long-term care, basically is to reduce the number of medications and optimize the medications for our senior population, especially the senior population that a consultant pharmacist focuses on the most, which are the folks that are in a skilled nursing facility, inside the nursing home. So I tell people all the time, I came out of school seeing how many prescriptions I could fill, and I have done an absolute 180 to I want all of my patients to be on the least amount of medication possible and make sure that medication is optimal for their condition, their age, and all the other functions that go on in their, in an older person's body that just aren't the same as, a younger person. And
I'm so glad that you mentioned that because, and I'm glad you took that 180 because as we, dive into seniors and their care, I've seen lots and lots of prescriptions that they have. So making that 180 and now focusing on the least amount that they can have to help them. I know our seniors out there would appreciate that as well.
I've definitely found that to be true. Really what I found is the hospital and a hospital pharmacist does a really great job optimizing therapy for the patient that's in the hospital and their condition. And No, you do cheat a little bit in the hospital because you have a lot more access to labs and real-time information and what's actually going on. But you learn to, accommodate a patient's renal function or liver function or hydration status or whatever it is that's wrong with them and going on with them acutely, and making recommendations or changing medication dosages to be optimal for those folks that are sick in the hospital. What I saw as working really in both areas, working in long-term care and working in the hospital, is it wasn't happening in long-term care. So really, when I came out, my whole goal, and it still is to this day, is to take all the things that are common practice in an acute setting, in a hospital setting, and try and relate them to the long-term care setting, because that's the best way, to take care of our senior folks and to make sure that nothing bad happens because of medications. If you look at statistics with medication errors and what they cause, a large portion of hospitalizations in the senior population is because of medication errors. And it's medication errors that you wouldn't think about, but as people get older, it just happens. It's a combination of drugs that may be too much, that someone didn't think about. It's seeing multiple prescribers and, one prescriber is not seeing what the other prescriber is doing. Everyone has the best intentions. Yes. Nobody's trying to hurt anybody.
Yes.
But and then going back to what you read in my bio, I really find that in that transition of care time, that time where someone changes from being in the hospital to going home, being in the hospital, going to an ALF, or going to a nursing home, or leaving a nursing home and going back to an ALF, or leaving a rehab facility and going back home, so many mistakes happen. And no one is there to be the advocate, and really focus on that particular time. Some of the hospital systems are incorporating that now, which is great.
Okay.
My wife actually works. My wife's a pharmacist as well. She works doing that. We work closely with a couple of other pharmacists that do transition of care in a hospital system that tends to discharge to facilities that Guardian takes care of. So we try and open lines of communication. It's really an area that it's overlooked, and
my follow-up question would be, as you are, I guess, trying to be there doing that transitional care, moving them from hospital to ALF or hospital to nursing home, are you then working with the nursing homes and the ALFs and in the home to say, let's take a look at these medications and see what we can do to minimize the amount you have? Or how does that work?
So, absolutely. So I'll use the difference that you have to think about is when someone goes to an assisted living facility, they're going home. Yes. They may have a different pharmacy, but that's their home. So they're treated exactly like they're going to their old house or their old apartment or their old condo, wherever they lived before. So now they're going home. When someone goes into a skilled nursing facility, you have a little more opportunity to make an impact because there's some rules that are already in place regarding reviewing med lists upon admission. So when someone is admitted or readmitted or has a status change in a skilled nursing facility, a consultant pharmacist like myself will review their medications. If they have a fall, we review their medications. If they come back from the hospital, we review their medications. Now, unfortunately, sometimes we don't have anything to review against. So we don't know maybe what they were on before, but we do the best job that we can with the information that we're given to make sure that nothing that is coming in today is dangerous. Nothing that is coming in today has any deleterious, side effects. Maybe And if it does, if it's something that might promote a fall or might promote, an electrolyte imbalance or want some of those things, at least we have the opportunity to talk to the providers at that moment and say, listen, can we make sure that we're ordering a couple extra labs, here in the beginning of them being back? Because, some of these drugs interact and it might increase some of their electrolytes. Mm-hmm. We have the ability to tell the facility and mention to the nurses, hey, you might want to be careful when this person's getting up and down because these medications, might cause them to fall or might, promote a fall. And of course, that's not something you want in any kind of a senior population. Mm-hmm. Mm-hmm. And when you have somebody that even is going to a rehab center from a fall, they unfortunately had a fall and they ended up in the hospital and they had surgery to repair whatever happened in the fall. Mm-hmm. And then they go to a rehab center. All they want to do is go home,
Yeah, and, that's so true.
But you can't, and I've lived this firsthand with my own family members. They can't go home the same way that they were before without trying to figure out, why did you fall the first time? Might have been an accident, might have just been a slip, but let's make sure it's nothing to do with your medication. So that's something that we try and focus on as well, for those folks that are in facilities, even for a short period of time.
Mm-hmm. That is wonderful. When I was reading it in your bio and as you were explaining it now to me and to our eavesdroppers, that is something I think people need to really, really start getting more into, especially the facilities, because having that consultant pharmacist there to actually review this instead of just taking the senior back and with this medication, going ahead and giving it to them and not, like you said, knowing the counter reactions that may happen or how this medicine is going to affect how they are now living. That is so important for them to know. And I hope as we continue this conversation and get this out to everyone that industry experts will actually start looking at this and getting this type of information, getting this type of, care for their seniors in their facilities and communities. I believe it's so important.
No, I agree 100%. Now, luckily in the skilled facilities, in a skilled nursing facility or nursing home, this type of review is required. In the ALF setting, it's not required. It's
not, because I'm familiar with the ALF setting and in-home care. Oh, right. So that's something very eye-opening for me.
Right. It's a huge opportunity as far as I'm concerned.
Yes.
Unfortunately, we haven't found anyone, we'll be politically correct. So we haven't found anyone that has assigned a value to that review process as of yet. And you would think, that preventing, preventive medicine has been around a long, long time, but in our senior population, preventing someone from getting the wrong dose of a medication, preventing someone from, and I'll use antibiotics as a prime example. If you can prescribe an antibiotic, whether it's expensive or not, if because of, we'll just use a patient's renal function, the way their kidneys work, right? The way they can excrete a medication. If their renal function provides that medication could be given once every other day for 10 days, and you get the same effect as if you give it twice a day for 10 days, why wouldn't you give less?
Yeah.
Why wouldn't you give optimal therapy? For optimal therapy, for ease of use, cost savings. Let's just move down the list. If they're in a facility, how many med passes did you just save? How much nursing time or med tech time or home care time did you just save? And that's where, to me, where the value is that, is just often overlooked. And part of it is not having information readily available. It's hard as a pharmacist if I see a prescription and it's a normal prescription and I don't know someone's renal function. I can't get it either, especially when, someone is saying, are you done yet? Are you done yet? Are you done yet? Are you done yet? Are you done yet?
Yes.
I'm done, and it's okay, but is it right? Is it the best choice? And that's where I think there's a huge opportunity. I think there's a huge opportunity to work with home care folks like yourself. I think there's a huge opportunity to work with ALFs and really just promote that idea and be able to, just help with optimizing therapy. And it's huge.
I am just learning so much from you right now at this very moment, because it's very eye-opening and it's huge. So eavesdroppers, take these nuggets, industry professionals, take these nuggets back to your communities, back to your ALFs, and talk to your executive directors, talk to that company and ask them to start looking more into consultant pharmacists, because they are so important. I can see the importance of the job that you do. So again, thank you so much for just your knowledge today, just getting us started. We haven't even gotten into, all the questions I want to get to you, but this was just a mouthful, a lot of information that I feel our eavesdroppers need to know. So thank you for that.
Oh, thank you for the platform. I know I tend to get on my soapbox about it, but I'm pretty passionate about that side of healthcare.
Yes. And as we talk about, medications and things like that, let's jump into prescribed medication. So for people who really don't know or want to know more, especially when they go to a pharmacy, what's the difference between a generic brand and a brand name of a medication? Or is it a difference?
So what can be different is the inactive ingredients in the pill or the capsule or whatever form that it happens to come in. The active ingredient is the same. The active chemical ingredient is the same. The inactive or the inert ingredients can be different. And there's some flexibility. And if you ask me to quote the number off the top of my head, I'll probably be wrong. But there's some flexibility in the concentration, but it's not really significant. So I never tell my own family or have told any of my older relatives or anyone who needed medication, only get the brand because that works better.
Okay.
Because I don't think there may have been a time where it was different. There are some medications, especially in the past, where there was a significant difference. The one that comes to mind is thyroid medications, and generics and brands had a difference for a time, but I truly believe in the day, the current state of affairs, and the potential for litigation and all that. Most of the time, 99% of the time, there's really no.
It's not a difference. So it's just kind of like maybe possibly the preference of the pharmacy or the insurance, or do the patient or the customer, do they get that choice?
So if you're filling a prescription, a retail prescription in the state of Florida, you're going to get generic unless otherwise stated.
Okay.
So if the doctor doesn't want you to have it, then that's fine. They can write it on the prescription. If you don't want to have it and you say, I want brand name medication. That's fine. What ends up happening is your coverage doesn't like that quite as much.
Okay.
And, they try and convince you otherwise.
Okay.
But everyone's bodies are different. Everyone feels differently about, what they're taking for medication. So it still is the patient's choice.
Okay. So as we, think about that as well, when some of our seniors are getting medications and sometimes they are not really feeling well, and certain medications may come in a pill form, are there different types of form of medication that a person can get, especially if they are not able to swallow? Or how can we help our seniors? How can we help me? Because I am not that kind of person that love to take, big pills. I would rather do something other than that. So what are the forms, and do seniors or do customers, do I have a choice as far as the form that I choose for my medication?
So yes and no. If your medication is available in a substitutable form that is easier to take, then of course, as a pharmacist, I want you to be compliant. So, if you say, hey, these pills by brand X, I just can't swallow them, but brand Z is, I know it's a smaller pill and it's the same medication, then I can order that for you without having to go through your provider and let them know that we made any type of changes, because it's an equivalent, it's like a different brand of generic. So going back to your brand generic questions, there is one brand of a medication. There are multiple generic manufacturers. So technically there's multiple generic brands. Okay. So if one brand is a smaller pill and one brand is a larger pill, then I can substitute the smaller pill for you. I can substitute a pill that is crushable. I can, make those kinds of decisions as the pharmacist to help you be compliant with your medications. If you say, I just can't swallow any of these pills and there's a liquid form available, I would need to talk to the provider to make sure switching to the liquid was appropriate. Okay. Sometimes you have to change the dosing. Sometimes, a liquid might need to be given multiple times per day instead of once per day on a sustained release form of a medication. So that type of thing. And when you have to get into those kinds of changes in a prescription order, you definitely need to talk to the provider.
And as a consultant pharmacist, would those be conversations, I guess, that you would be having about the patient or client that you are consulting about when they are getting ready to transition back to their home?
Absolutely. So we have those types of conversations all the time. Now, again, most of the time, a consultant pharmacist is in a skilled nursing facility. Okay. We hope that people would transition back to their home, but oftentimes they, continue to decline. But some of those disease states that cause these declines, dementia, it's out there, Parkinson's, they can affect your swallowing. They can affect your, the ease at which you take medications. And when you look into those types of folks, then as a consultant, you can start making recommendations of, hey, we noticed that, this particular resident didn't really do well on their last swallow study. Maybe we can think about changing some of these to a crushable form that could be mixed with liquid or a thickened liquid or applesauce or something that might be a little easier for the patient to swallow. Those are the types of recommendations that, as a consultant pharmacist, I enjoy, because I feel like it's really making a direct impact on that person, that how they take medications, every day.
Yeah. And you are that consultant.
Yeah. It's really, it's a neat field.
Yes, I see. The more and more we talk, the more and more I'm interested. I'm like, Okay, I see. I just, like I say, I'm blown away just by the conversation that we've been having, knowing that this is out there, and it should not only just be in skilled nursing, it should be in-home care, it should be in assisted living facilities, it should be there. So the more people know about it, the more they are able to say, yes, this is something that we would want to do. Definitely. So as we continue to talk about prescribed medications, and you know, thinking about being the people that you help as a consultant pharmacist, let's take a look now. Let's dive a little bit into prescribed medications. And I know this wouldn't happen on your watch or at a skilled facility, but thinking about prescribed medications and the expiration date of those. A lot of our clients that we have to deal with, they have medications that are in their home, and you open it up and you got stacks of medications and expired medications, and they're still like, oh, that's some good. I want to still take that. Or they've had something 2 years down, in their cabinet, and they're saying, I want to keep that. How are they? Can you do that? Can you use expired medication?
Well, my question is, because I was always taught as long as it's in the refrigerator, it's okay. Because I grew up with grandparents and parents that hoarded their medications for years in the refrigerator before I became a pharmacist. And so they said, oh, as long as it's in the refrigerator, it's okay. And but what happens usually is medications lose potency. Over time, and it could be as easy as an interaction with air. One of the medications that comes to mind, I'm sure you're familiar with it, and I'm sure the listeners hopefully are familiar with it, is the sublingual nitroglycerin tablets. Little tiny pills. We have chest pain and I got to put my pill under my tongue. Once you open that little tiny bottle and air goes in there the first time, you have 6 months before the air, the oxygen that went in the bottle, degrades the tablets to where the manufacturer can't assure that they're still going to be effective the next time you need to put one under your tongue. And so it's not anything anyone did. They're not even sitting around for years. It's just that they degraded because that bottle was opened the first time because someone needed one of those medications. And that's the prime example that I use all the time. There's eye drops that are often kept for months and months and months and months and months. But they're only good for 6 weeks,
Oh, really?
Some. There's some inhalers that are only good for 6 weeks. If you read the package, it says it's. Now, do you want, as a person who needs an inhaler, to depend on that inhaler if it's only good for 6 weeks and it's been 6 months in that particular instant that you might need it?
Oh, wow.
So that's where I don't think, for the most part, there's and none really come to my head. I'm sure someone could correct me on this, but for the most part, the medications don't become more potent and dangerous. They become less potent.
Okay.
And therefore they're dangerous because you're depending on them to do something and they may not.
They may not do it.
Even if it's a pain, a lot of people, especially now, like to hoard pain medications.
Yes.
Not for any nefarious purpose, just because they're hard to come by, and when someone is in pain, if this older pain medication isn't as effective, well, I'm going to take another one. Well, now where are you? Because what if the next one is more effective than the first one that wasn't as effective, because they don't all degrade at the same amount of time, So that's where I think it's definitely a good practice to just go by the expiration dates that are on bottles, go by the expiration dates that are on packaging, read the packaging, which is my pet peeve as a pharmacist, because there's a lot of information on packaging that no one reads.
It is.
A lot of the auxiliary labels, I'm sure you've seen prescriptions that have all these stickers on them.
Yes.
They're not there just for decoration. And they're not there because pharmacists like to put stickers on things. They're there because they all contain, bits of information that are helpful when it comes to taking the medication. Even, the take with food. Well, I don't want to take this with food because I'm on a diet. Well, okay, but when you have an upset stomach, don't call the pharmacist because it says take it with food. Now, it doesn't say take with food because you're going to get nauseous, but that's the implication. We're trying to help you along. So hopefully I answered your question. I know
you did. You did answer it. And I think as I was doing my research, getting prepared for this this interview with you, you being in the guest chair, that was the number one question as I was asking questions to other people. They wanted to know about that expiration date. So definitely you answer that. All right. Thank you. Thank you. Now, as we continue to talk about prescribed medication, antibiotics was the second question that everybody wanted to know about.